Welcome everyone. My name's David Reid. I'm the Director of Trauma and a trauma and colorectal surgeon here at the Royal Melbourne. And it's my pleasure to introduce all the speakers today and get us all kicked off here. So I'd like to start off by acknowledging the traditional owners of the land that we're meeting on now, the Wurundjeri people of the Kulin Nation, and pay respects to elders past, present and emerging. And I'd also like to point out it's just not the lands of the Wurundjeri that we're presenting to, and it's nice to have real people in a real audience for once, but we're also live streaming and we have registrants from all over the world, not to single any people out, but over in the Pacific, the Middle East, Europe and in India, although the latter people may be a little bit sad after the result of the cricket. So this meeting will be available, we record it, and after a little time we'll have it up on a web, so if there's anything you missed or want to see again, or if you want to recommend it, you can do so. For questions, we recommend you use the Slido app, which you can download via this QR code. If you missed this, the link is has been sent on you on the program if you've registered. But I'll just give you a minute there. We have a wonderful program as outlined here today with many speakers, and the topic is of course pelvic trauma, which I think is the epitome of the multi-trauma injury. It has so many aspects to it and so many different challenges, right from roadside to rehabilitation. So I'm going to start off with a little bit of a presentation of a background. So to put it in perspective, there's the Royal Melbourne has just under 6,000 trauma admissions a year, and about 1,200 of those were major trauma. So of those, there's around about 200 pelvic fractures a year. So it's a not insignificant proportion of the work we do. And the type of fractures we have, well, the acetabular fractures are a little bit different, but you see the majority there are a ring fracture with the ring intact. And then as severity increases there, with the ring more and more disrupted, the numbers go down, but it's still a reasonable number. They're a major cause of our workload. Their length of stay is long at the median of a mean of 16, and they're often in ICU for several days, as I'm sure all of us would be aware. And their median ISS is 21, saying that the vast majority of them are well and truly into the major trauma cohort. The mechanism of injury, no surprise, mostly transport related and high falls, with motor vehicle crashes being the most predominant mechanism, but also other mechanisms such as cyclists, and My Little Pony down there is not uncommon, especially with Flemington Racetrack down the road. But it's not just about the bones, Ruben will be disappointed to hear, but there are a significant amount of squishy organs inside the pelvis, and they're at risk, and that's perhaps, they're a little bit of an orphan topic in pelvic fractures, and we're hoping to address that moving forward. So of the, on our database, the close to 1,800 pelvic fractures we have, around about 2% of them will have a urethral injury, and that will have ongoing lifelong implications. Another couple of percent will have a bladder injury, and an unlucky 0.5% will have both. 0.7% will have a rectal injury and will often result in needing a defunctioning with a colostomy and subsequent reversal with a less than certain functional outcome. And a very, very unlucky 0.2% will have the trifecta of rectal injury, a urethral injury and bladder injury. How we manage them, and this is of interest in that the two major trauma centres in towns have a slightly different philosophy of how to approach them operatively, but it's interesting in the way that the results seem around about the same. Here at the Royal Melbourne, we change our binders over to a larger binder, less likely to cause pressure injuries, and keep them in that until internal fixation is appropriate, rather than use external fixation, which is used occasionally, but not as frequently as elsewhere. And I draw attention to the last number there is just under 10% of people with pelvic fractures pass. So it's a marker of a serious injury with substantial mortality, not unsurprising with those injury severity scores that you saw. So with that, I'll thank you for your attention to start off, and we will move on to our case presentation to set the scene. And so I'll invite Dr. Alicia Sutherland, who is a trauma and general surgeon and the fellow here at the Royal Melbourne Hospital, to talk about her case. Alicia is originally from Aotearoa, New Zealand, from the Waikato region, and has nearly finished her trauma surgical training. So welcome, Alicia.
Kia ora, everyone. Our case this evening is a 45-year-old male. He, on the 21st of February 2017, at 12:16, was working in a factory, and he was standing behind a large excavator that unfortunately started reversing into him, struck him down, and then completely ran him over. At that time, he remained screaming on the ground, calling for help, and an ambulance was called by his workmates. Initially, on arrival of the ambulance crew, he said he couldn't move his legs and he had pain that was described as 10 out of 10. The ALS crew at the scene requested Micah backup. His initial observations were a heart rate of 126, an unrecordable blood pressure. His respiratory rate was 20 and he was saturating at 100%. He was completely conscious the whole time, did not lose consciousness at any stage. He had a really nasty, large laceration in his pubic region, which was actively bleeding and was controlled at the scene with manual pressure. With fentanyl and ketamine use for analgesia, he was placed in a cervical spine collar and a SAM sling pelvic binder. Given his wounds, they were unable to put any traction splinting for his lower legs, but they were anatomically aligned. With all of this at the scene, this took about 35 minutes. He was given 2 litres of normal saline en route. The flight to the Royal Melbourne Hospital took 20 minutes. Given his observations, he met the requirements for an RMH trauma call. On arrival, this was his primary survey, most remarkable for hemodynamic instability, with tachycardia at 96 beats a minute, and he was hypotensive at 65 systolic. His fast scan was negative, which lowered everybody's suspicion for an intra-abdominal cause of his instability. He had suspected open pelvic fracture, given that large open wound, and degloving injuries to bilateral lower limbs. His blood gas was consistent with his observations and his instability. His pH was 7.18, base deficit of 6.8, and a lactate of 2.5. Within 10 minutes of his arrival in the trauma call activation, he was having lines placed, resuscitation started, and the adjuncts to the primary survey completed. This is his initial chest X-ray and pelvic X-ray. The chest X-ray is pretty unremarkable, so no cause for his gross instability there, but the pelvic X-ray shows a vertically unstable open book pelvic fracture. Over the next half hour in the emergency department, he was intubated for humane reasons just because he was so sore and log-rolled with no further findings. The picture from the notes here just demonstrates how difficult it is to interpret handwriting pre-epic. His ambulance-placed pelvic binder was reinforced with our RMH 3-strap binder. Dressings were applied to his lower limb lacerations. Over this time, he'd been given the content of 2 massive exsanguination packs, with transient improvement in his systolic blood pressure, as noted with the green numbers, but as you can see, his blood pressure would drop again relatively quickly, and he was persistently tachycardic, in keeping with his being a transient responder to resuscitation.
So we'll pause there and break down piece by piece, and I'll invite now Dr. Rose Shakarian, one of our trauma and general surgeons here at the Royal Melbourne, to talk about decision making at this point of time. Rose not only has an interest in trauma and emergency surgery, but also abdominal wall reconstruction. So thank you, Rose.
Thank you, David, and thank you to Alicia for presenting the initial aspects of our case. I just want to take this opportunity to thank you all for your interest in this topic and attendance, both for those of you online, and it's lovely to see actually people attending in person. I hope you find the seminar engaging, informative, and useful. I'm going to give you an overview of decision-making in patients who present with suspected pelvic injury, and I will focus mainly on the unstable patients. Now, failing the test, let's just see it, here we go. Okay, I should say that the purpose of my talk is to set the scene for the subsequent presentations this evening, so it's an overview. My colleagues, you will see, that will cover many aspects of this presentation in far more detail. David has already touched on the incidence and mortality based on the Royal Melbourne data, but I just will give you a quick overview. Pelvic fractures overall account for less than 5% of skeletal injuries in trauma patients, and it's not surprising to see the younger male patients being overrepresented in this group. The overall mortality ranges from about 5 to 16%, but it's important to know that in patients who present in the shocked state with suspected pelvic injuries, this mortality can rise to as high as 45%, so quite significant. Most fatalities in patients with pelvic trauma are in fact related to their associated injuries. And the study from the US demonstrated that in patients with suspected pelvic fractures who succumb to their injuries within the first 6 hours of their presentation, the underlying cause tends to be uncontrolled haemorrhage, followed by traumatic brain injury and multi-organ failure, which accounts for death beyond the 6 and 24-hour mark, respectively. The commonly associated injuries with pelvic fractures that can result in significant morbidity and mortality, and David's already touched on this, include thoracic trauma, traumatic brain injury. With intra-abdominal injuries, the solid organs, particularly the liver and spleen, are the usual offenders, followed by long bone fractures and urogenital injuries. It's not surprising to note that it's the high-risk mechanism or high-velocity mechanisms that result in pelvic fractures. And in our patient population, this tends to be commonly in road-related events, followed by falls and crush injuries. I'm just going to make a note about falls. Whilst young patients fall from great heights and can present with instability and significant pelvic trauma, we mustn't forget our elderly patients, as we continue to see an increasing presentation of patients over the age of 65 who sustain significant pelvic injuries as a result of fall from standing height. Their management these days is often made extra challenging through the use of anticoagulation therapy, so we mustn't forget them. Just a note about pelvic hemorrhage specifically, and to bear this in mind in the next few slides. There are 3 sources. So you've got vascular bleeding, venous accounting for the majority, followed by arterial in 20% of the patients, and also bleeding from the bone surfaces. I will not be covering the detailed anatomy of the pelvis. This is just there to remind us that in addition to the fractured bones, there are a number of other structures that can be damaged, and these include the urogenital and reproductive organs, the rectum and anal canal, and a whole host of blood vessels and nerves. Now, this slide is summarizing some of the text messages that I've received on my phone as part of the trauma team activation here at Royal Melbourne Hospital. This is in the first 3 weeks of October this year. I think I counted about 25, but managed to only fit about, 16 or so here. The idea is to show you that here at a level 1 adult trauma center, it is rare for us to receive a patient with an isolated pelvic injury. Our patients tend to have been subjected to significant mechanisms of trauma, and they often present with competing injuries or in conjunction with their pelvic fractures that can be life-threatening. You can see here there are a couple of patients whose injuries are due to motorbike accidents, a young patient who's fallen from a ladder, a patient trampled by a horse, and a female driver involved in a high-speed rollover. All of them have been flagged as potentially having pelvic fractures, but they have other injuries as well, as demonstrated in the CT scan. This is one of our patients who was involved in a high-speed motor vehicle collision, whose initial scans pointed to a pelvic fracture with a positive FAST scan. They were stable to proceed to a CT scan, which demonstrated or confirmed the hemoperitoneum, but they also have active bleeding from their kidney and spleen, and in addition to the pelvic and intra-abdominal trauma, they have significant chest injuries with multiple rib fractures and a moderate-sized hemothorax. So when we have an unstable patient with pelvic fractures in the emergency department, there are multiple competing elements, lots of decisions to make, lots of interventions. It can seem quite chaotic. I find it at times overwhelming. So how do we make sense of this? When it comes to decision-making, I think our management is ultimately dictated by the mechanism of trauma, but more so by the patient's physiology and the patient's response to our resuscitation efforts. Are they responders? Are they transient responders? Or are they completely unstable? Our management decisions clearly depend also on our local resources and available expertise. With respect to mechanism, knowing that it's a high-energy trauma will raise the index of suspicion for hemorrhage and associated injuries. We like the stable patients because in those patients, time is on our side. We can complete our trauma assessment, our scans, and offer interventions as required, but the unstable patients are quite challenging. It's important to recognize for these patients the potential for significant injuries, but also the fact that they can rapidly deteriorate. You saw that the young male patients are overrepresented in this group. They're fit and healthy. They can present essentially stable and give us a false sense of security and then rapidly decline, become hypotensive, tachycardic, and be peri-arrest. So activation of the trauma team is very important. The management is multidisciplinary, as reflected by our speakers here this evening. Because these patients can bleed significantly, early activation of the massive transfusion protocol is essential, and we aim for goal-directed resuscitation to minimize trauma-induced coagulopathy. The pelvic binder, thankfully, is on. Our paramedics are very good at applying this at the scene, but we have to make sure that it hasn't moved, that it's in the correct place. The unstable patient with pelvic trauma is bleeding until proven otherwise. As mentioned before, they can have multiple bleeding sources as a result of significant volume of blood loss. They can be coagulopathic, cold, and acidotic. I find them particularly challenging because unlike external wounds where you can put your finger on it and apply direct pressure or apply tourniquet, you can't really do that with pelvic fractures. The best thing we have, or the closest thing, is a pelvic binder, which, to be fair to the device, can actually be quite effective, but more so in patients who have predominantly venous bleeding. And the unstable coagulopathic patient who also has arterial bleeding, it will not be your definitive intervention. Patients with pelvic fractures, as you saw in the pages that I showed you, often the multi-trauma with multiple causes of shock, and we need to rapidly identify and manage these. And in order to achieve this, we follow the ATLS guidelines, clinical examination through the primary and secondary survey, supplemented by our X-rays and EFAST, assist with rapid diagnosis of conditions such as hemopneumothoraces, cardiac tamponade, intra-abdominal bleeding, external wounds, and airway obstruction. We can do this very quickly. Now, this is a trauma talk, so we can't have a trauma talk without trauma algorithms. I've got an example of 3 here, the Royal Melbourne Hospital ones that were revised in 2018 and are due for revision soon. The World Society of Emergency Surgery published in 2017, and an up-to-date guideline that summarizes predominantly the North American experience. Now, this is a Royal Melbourne talk, so we'll spend a little bit of time just looking at our guidelines, which I think once we update them will include our hybrid theatre as part of it. A note about the guidelines: I don't think there is any controversy about the initial assessment and resuscitation measures for these patients. When it comes to the techniques used or the timing of pelvic stabilization and hemorrhage control, I think it very much depends on the local resources and expertise. At Royal Melbourne Hospital, the fork in the road for us is the FAST scan in the unstable patients. So if we have a patient with confirmed pelvic fractures on the X-ray and their FAST is positive, we've identified intra-abdominal bleeding as a potential contributor to their instability. At Royal Melbourne Hospital, these patients are transferred to their operating theatre where they undergo damage control laparotomy and they proceed to angiography and embolization as required. It's unusual to proceed with external fixation in these patients. The binder seems to be quite effective once the damage control laparotomy and embolization have been performed. If there's no intra-abdominal bleeding, so a negative FAST, then we can be relatively confident that the bleeding is from the pelvis, and these patients, whilst they're being resuscitated, are transferred to angiography for embolization. Again, the external fixation is really dependent on the individual case and not. They don't frequently go on to have external fixation. I have pre-peritoneal pelvic packing in very tiny fine print because we don't use it here at Royal Melbourne Hospital. In fact, in the last 15 years, I can only think of 3 patients who've had this procedure. Now, just because we don't use it here at Royal Melbourne Hospital doesn't mean it's not effective or shouldn't be used. To give you an example with the North American experience, if you look at the patients with negative for intra-abdominal fluid in the lower box, they in fact use pre-peritoneal packing ahead of pelvic angiography. So there's a role for it. And I think for the sake of time, I might leave that either for the panel discussion or our interventional radiologist might touch base. A quick slide on pre-peritoneal pelvic packing. It's a surgical procedure. The idea is to enable placement of surgical packs in the periperitoneal space. It reduces the pelvic and retroperitoneal volume, tamponades bleeding, quite effective for venous bleeding and bleeding from bone surfaces. But again, it's often supplemented with pelvic fixation or angioembolization. So my last slide is to just bring everything together. The management of these patients can be quite challenging. We need to consider the mechanism of injury, the patient's physiology, and the response to our resuscitation efforts. The unstable patient with pelvic trauma is bleeding until proven otherwise. We treat them as if they have hemorrhagic shock. Their associated injuries can be fatal, so it's important to rapidly assess and identify these patients for their injuries and treat them to increase their survival. And this all obviously depends on local resources and expertise that are available to us. Thank you.
Thanks, Rose. So next we've got a talk by Dr. Juliana Koch, who's one of our trauma anaesthetists here at the Royal Melbourne Hospital and also a supervisor at training for the College of Anaesthetists. And she's going to be talking to us about the hybrid operating suite.
Thanks, David. Right, so I've been asked to speak very briefly about the hybrid operating theatre here at the Royal Melbourne. I'm going to aim to give you a broad overview with a slight anaesthetic slant to it. So the rationale behind the hybrid theatre, obviously, it's an operating theatre. It allows us to perform both angiography and embolization via fluoroscopy. It is located in the main theatre complex, so it also means that simultaneous interventional radiology work and surgery can occur if required. As Rose has already highlighted, you can get fairly significant bleeding in pelvic fractures and multi-trauma, and so the hybrid theatre would be mainly useful in angioembolization of significant arterial bleeding. And obviously, with Rose's earlier slide, we know that time to definitive hemorrhage control can help determine mortality. I've got here a photo of the hybrid theatre set up for pelvic surgery. I'll go through it in a second, but I just wanted to talk about the advantages that the hybrid theatre may provide for us. So the first one, and the most obvious one, is minimising number of transfers that a hemodynamically unstable patient has to undergo. So instead of 2 separate transfers to angiography followed by the operating theatre, you just have 1 single transfer to the operating theatre. For those of you who are not aware, at the Royal Melbourne, the hybrid theatre is located on the 3rd floor with the main theatre complex, while ED is on the ground floor and angiography is on the 1st floor. So you can imagine the difficulties in transporting a very unstable trauma patient on 2 separate occasions to 2 separate floors. Right, so the other thing about the hybrid theatre is obviously it lets us do on simultaneous surgery and interventional radiology. The damage control surgery aspect of it would include the angioembolization, and also if we decided to do external fixation, the equipment and the staff are they're ready for it. It may reduce the time to definitive hemorrhage control, and it may reduce the ongoing blood transfusion requirements as well. I want to talk about ongoing resuscitation. For those of you who've had the opportunity to visit the angiography rooms on level 1 here, it's a pretty small room. And speaking as an anaesthetist, there's not a lot of room to allow ongoing massive resuscitation in that space. We are a little bit greedy. We do like a lot of space when we do our resuscitation. And, you know, it gets pretty crowded, it gets pretty noisy. So, this is a pelvic setup for pelvic surgery. This is our hybrid theatre. It's a huge space in comparison to what we have downstairs on level 1. You can see our patient, surgeon here, scrub staff here. To the far right would be where the scrub staff would have their setup. That glass wall there hides the radiographers and everything that they do. And this is the C-arm. So currently the C-arm is retracted back. During surgery, it comes in, the surgeons can control where it goes, and it means that the surgeons can control where the C-arm moves, and that helps them with the surgery and also with sort of the efficiency of it. And there's our anaesthetist. All right. Some of the challenges with the hybrid theatre, obviously significant capital cost setup, expensive infrastructure needed. So, whoops, how do I go back? Oh, there you go, sorry about that. So, this is the theatre before it's set up. We have 2 anaesthetic machines in our hybrid theatre, and that's to allow any positioning requirement for any surgery or interventional radiology that's going to take place. It does require a fully trained team, including a radiographer on standby, to facilitate this. And although the room looks enormous with so much space, once the patient's actually in there and the C-arm has been brought in and all the equipment has been brought in, it actually means that we have much less access to the patient than you might think you would have. Still better than the angiography room, but much less. The hybrid theatre at the Royal Melbourne is a shared resource. So currently we actually do run elective lists in there, mostly vascular lists. So it may mean that on occasion, when a multi-trauma patient does come in and requires immediate access to the operating theatre, it may be a short delay. And finally, there is a lack of consistent evidence to demonstrate benefits of a hybrid theatre in regards to in-hospital mortality, lower blood transfusion requirements, and the time to definitive surgery. Thank you.
To continue our case, our patient is now 55 minutes into his hospital presentation. The interventional radiology team has been contacted given his pelvic fracture and his hemodynamic instability. And he's transferred to the angiography suite, so not the hybrid theatre. I actually believe that in 2017 it was pre-hybrid, so it wasn't available. And he's transferred to the angiography suite for embolization. Here are his angiography images demonstrating the aortogram and the superficial femoral artery. This was imaged in the suite due to the significant lower limb injuries to check for any active bleeding. These are the pictures of his internal iliac arteries. There wasn't actually any active arterial bleeding at this time, but given his instability, he underwent internal iliac artery gel foam embolization.
So next I'll invite to the podium Dr. Connor Houlihan, who is one of our interventional radiologists. He completed his basic radiology training in the Republic of Ireland before moving here to Melbourne, presumably for the weather, and he's going to talk to us about the interventional radiological management of it.
Thanks very much, David. Good to see everybody here. It was great to hear Rose and Juliana speaking about the decision-making pathways around pelvic trauma, which is really one of the most critical aspects of the whole thing. So it does get to a stage where after so many cases, the technical aspects of what you're trying to implement becomes more straightforward, although still challenging, but the decision-making is really critical around all of it. And the hybrid theatre has made a big difference, especially to those shocked patients. Let's see. Okay. So what can we offer from an endovascular point of view in interventional radiology? So we do most of our work, or nearly all of our work, through the inside of the blood vessel, so endovascularly. We can approach nearly any territory in the body. Obviously today we're talking about pelvic trauma. We can also tackle renal, splenic, hepatic, retroperitoneal, facial and lower limb or upper limb injuries as well. And as was alluded to earlier, there's a significant association with additional injuries in pelvic trauma owing to the the degree of force involved. So, as we said, one of the largest causes in the early time frame after high velocity injury, whereby bleeding counts for 36-54% mortality if there is shock on presentation, and between 5 and 15% overall if the patient arrives, and they can be resuscitated to hemodynamic stability. The risk of bleeding correlates with the type of fracture, so I'm not sure if you have seen this, but we would split the fracture patterns based on the vector of the force. So we can see in the top row there's a lateral compressive force. Middle row then we've got an AP compression, which can result in this open book type fracture, and then a vertical shear. And often there can be mixed patterns of injury. The risk of bleeding correlating with the type of fracture, whether it's arterial, venous, bone, as we've touched on already. And also, as I'll go through in the next slide, the location of the fractures will give us some information as to which arteries would be injured. Venous bleeding, again, 80% of bleeding in pelvic injury, but largely controlled with compression, so pelvic binders, external fixators, and correction of clotting dysfunction, which again is critical to the management of the patient. So this is just a slide outlining the anatomy of the internal iliac artery. So as we can see here, it splits into a posterior division and an anterior division here. The posterior division is made up predominantly of the superior gluteal, lateral and sacral and iliolumbar arteries, and these would mainly be affected by fractures which involve the posterior aspect of the pelvis, so sacrum and iliac bone, as well as the sciatic foramen here. And then the anterior division has a number of arteries which run towards the pubic rami and the obturator foramen, and also supplies visceral branches to the soft squishy organs that we heard about earlier, which we hopefully won't neglect. So arterial bleeding arising from bone, we can't really do a huge amount endovascularly, but this, high volume bleeding from transected or otherwise injured arteries is really the target of what we're trying to, improve. So just as they're numbered here, we've got iliolumbar arteries, which would be affected from sacral or sacroiliac joint disruption, and then lateral sacral, again, similar. Superior gluteal, which passes through the greater sciatic foramen above the piriformis muscle, which we can't see. And again, that's just something else to take into account is The X-ray will offer a lot of information around the bones, but there are so many ligaments, soft tissues that aren't appreciated on X-ray, but are nevertheless at risk of injury. Inferior gluteal artery then also liable to injury through fractures to the ischial tuberosity, or ischial spine, and then internal pudendal obturator arteries as well through fractures to the anterior aspect of the pelvic ring. So it's a very broad spectrum. The focus, in this talk is to, highly unstable patients, unstable at the time of presentation, at best, transient responders to resuscitation. But that's one end of the spectrum, and on the other end are, we'll say, very stable patients who don't have disruption of the pelvic ring. So we can see here. Oh, sorry about that. So this is just a linear, minimally displaced fracture through the iliac wing. Again, this is associated with some intramuscular hematoma, and we do have some stranding in the fat of the pelvis. But this is a stable injury if there are no other injuries that we're not capturing on this slice. Whereas if we look at this X-ray, this patient would likely not have been stable enough to get a CT before treatment. But we can see here there's a large open book pelvic fracture. We've also got fractures of the superior and inferior pubic rami, and we've got disruption of the sacroiliac joint on the left for sure, with widening of the inferior portion. And there's also some widening here as well. And the whole idea behind this and why this is such a key point to kind of impart is the volume within this space increases drastically if this injury isn't contained by the pelvic binder or external fixation. So if there is any active arterial bleeding or even venous bleeding, there's a huge volume here which can occupy that blood. A similar point would be if the fascia which encloses the pelvis is disrupted, so the gluteal fascia or the peritoneal lining. So if there's a rent in that, which can allow blood to escape from the pelvis into the peritoneum, that can also increase the volume that blood can occupy and reduces any tamponadic effect that an intact pelvic ring would have. So I'm just going to go through a couple of scenarios, just to kind of illustrate the algorithmic approach and the decision-making aspect. So we'll say in this first scenario, a gentleman with trauma, on arrival, shock, and then is fast positive. So as was mentioned, this is a point of dichotomy or a split in the algorithm, whereby the fast positive patient would generally, after having a pelvic binder placed, proceed to a trauma laparotomy for damage control. As we said here, we don't actually do preperitoneal pelvic packing. However, that is an option, but would assess for any other injuries in the abdomen. If the patient is still unstable after the damage control laparotomy, then they can proceed to embolization and then CT once stable to assess for additional injuries. And this is really the advantage of the hybrid theatre, that all this can be done in one room. And if you really did see our angio suite, it is pretty, I suppose a real estate agent might describe it as cozy, but it's quite small for space, but yeah, we do love it all the same. If stable, again here, might apply the pelvic binder and just keep that on for a prolonged state. Other centres may use external fixation earlier, then proceed to CT and embolize if arterial bleeding is found. The CT is amazing. Like, if you can get to CT, it imparts so much information. Not only does it help us to target where we would embolize, which vessels to address initially, but also identifies any other injuries that may not have been picked up either on the primary survey or on the initial laparotomy. If there's no pelvic hematoma and the patient remains stable, CT or watchful waiting, but again, driven by the patient's hemodynamics, whether they're stable or not. Then this is effectively the same thing, except the patient is fast negative, in which case a pelvic binder would be applied, skip to trauma laparotomy and proceed to embolization. Again, the hybrid theatre does offer the opportunity to change algorithm if ever necessary, and also gives a lot more space. And to be fair, the anaesthetists do prefer to work in that space. And I think they refer to angio as the dungeon. Again, if the patient does respond to resuscitation, the CT scan, it just offers so much in terms of patient management and triaging and next steps. As you might have noticed, so I'll touch on this in a second, but the way we access the circulation is generally through the right common femoral artery, which runs across the hip. And this pelvic binder, although does offer great stability and reduces risk of pressure sores, does make it difficult to access the arteries. So we would generally unbuckle one of these in order to access. But I think it's important to stress as well, the additional binders do maintain stability, so that's an advantage. So do's and don'ts, very important to keep your goal in mind, so what you're trying to achieve, to be relatively quick while always being safe, but not to get too fixated on any one thing. So the pelvis obviously has bilateral blood supply, but we can only look at one side at a time. We would do a flush aortogram which looks at both, but often this won't pick up every injury. And when we do a selective run, so one side selected just to look at that side, we get a better injection and we can isolate injuries more clearly. If we did see an injury in a very distal tortuous vessel, it can be tempting to spend a lot of time trying to navigate to that vessel and that injury and just to selectively embolize that. But often, you could waste more time than you realize trying to do this, whereas it's much more important just to achieve hemodynamic stability, resuscitate the patient properly, and warm them up, correct any coagulopathy, and just stabilize the patient. And any of these more, I suppose, nuanced or these finer injuries, if even necessary, can be tackled at a later stage. The importance of the hybrid theatre, as before, and as in the case that Alicia is presenting, if we don't see any injury, we would always, or any active extravasation or pseudoaneurysm, we would proceed to gel foam embolize the internal iliac vascular bed anyway. So that will massively increase the systemic vascular resistance. If there is any bleeding that we haven't identified, it will take care of that. But it's important to remember that it's temporary, and it is important to consider repeat angiography if the patient doesn't remain stable and no other cause for instability is identified. So this is just to illustrate how small the vessels can look in a shocked patient. So we've got the external iliac here, and then internal iliac, and then again internal iliac, external iliac, and again the posterior division, anterior division of the internal. And these vessels are so thready that you can imagine if we are injecting gel foam into this area, it would take the volume of gel foam that we'd inject wouldn't be representative of what is really required once the patient is fully resuscitated. So often it's important to maybe give a second look, or at least keep in mind necessity for repeat embolization. In this image here, we can see there is contrast blush coming off the posterior division here. And we've also got some irregularity here superimposed over the anterior division, but we'll come to that later. And then there is some prominence here, but it's often a branching pattern. We can rotate the angiography tube just to give us multiple different angles, and that's something we do routinely, as just a single AP view often doesn't give an appropriate, degree of information around the anatomy. How do we do it? So as I said, we've got a right or left, so depending on where the main fracture is, we would start on the contralateral side. And the reason that we do that is that it gives us a better approach over the aortic arch to access the internal iliac. So it's generally easier to access the internal iliac from the contralateral side coming up and then down. Again, the flush aortogram, if we don't have a CT to guide us initially, if the patient can have a CT at all, it does, I know I've said it a few times, but it really does make it a lot more selective and a lot more straightforward. Definitely remember the external iliac artery, and particularly if there are anterior pubic ramus fractures, and I'll show why in a second. No active bleed, gel foam slurry. If badly shocked, then consider repeat. If we did see active extravasation or pseudoaneurysm or selective transection of a vessel that we could get to safely and expeditiously, then we have a number of ways of blocking those off. So we can use very, very small coils, so they're in the order of 0.035 or 0.018 of an inch, so 18 thousandths of an inch in diameter, so they're very, very small. We can use N-butyl cyanoacrylate or a glue, which is very, very effective. It does have higher risk of non-targeted embolization. And if there are larger defects in some of the arteries, we can use covered stents to address those. So again, this is just to show that previous case, and this injury here was actually arising from the inferior epigastric artery. So again, you'd have to select this to block it off, because you can't gel foam down the external iliac artery for obvious reasons. So again, just to go through the algorithm a bit further. So if things are unrevealing, we don't have to, we're in the circulation already. We are there. We can take a look at the lumbar arteries, renal arteries, and splenic, even hepatic as well. If we haven't found a source, or even after embolization, the patient hasn't stabilized. So the patient tends to respond quite quickly to gel foam embolization if that's their main problem, and it's quite satisfying and reassuring to see the hemodynamics improve in real time as you're doing the procedure. If a CT or laparotomy has been performed, and we're in constant communication with each other, with the surgeon, with the anaesthetist, seeing what has been found, what the I suppose highest index suspicion injury is, and again talking to the anaesthetist to see how the patients are responding to what we're doing. So it's a really collaborative effort, and the level of communication, it's difficult to overstress how important that is. Again, don't be too fancy. Better to get the patient to ICU after you've performed some embolization, correct coagulopathy, and then get the CT scan if it hasn't already been performed. And I'm just going to go through a few images of active extravasation and what it looks like. So although it wasn't the case in the case being presented today, we can see, and most of these patients had a CT scan just to show correlation between CT and angiography. So here, this would be, just on the deep surface of the iliac wing, and we can see here this active blush, and then this soft tissue area here is the iliacus muscle, which is hugely expanded by intramuscular hematoma. And then as we do this is posterior division of the internal iliac artery on the left, so correlating to this, we can see there are multiple areas of extravasation, but no true pseudoaneurysm, but definite contrast blush. And then here this is more posterior. So again, it's correlating the fracture location with the artery injured. We can see a huge blush. Well, huge is probably overstating it, but it's quite an impressive contrast blush. Yeah. But again, the patient may well have been resuscitated. Often the size on CT doesn't correlate with the size in angio. We can see here, this is a lateral sacral artery injury and extravasation. And then we've got superior gluteal. So again, close to the lateral sacral, and we've got this lobulated area, so pseudoaneurysm at this stage of the superior gluteal. Complications. So this looks like a long list. I would like to excuse, radiology and say that a lot of these are related to the injury itself. It's very, very difficult to separate the etiology of the patient's end outcome from the procedures or interventions they would have had along the way, in conjunction with the degree of injury that they would have had to begin with. But one thing I would like to just draw attention to would be, well, there are a few, but non-targeted embolization. So when we're injecting the embolic material, we're not that far away from the common iliac artery and internal iliac artery. So it's important to be aware that we can embolize the legs if we aren't careful. Anytime we're involved in we're accessing the blood vessel, there's a chance of infection, dissection, or bleeding. And then the one thing that I'd like to mention would be, can't see it here actually, but we can cause tissue injury. So I guess it kind of fits into rhabdomyolysis. So let's say if you performed a proximal coil embolization, the tissue distal to that should be supplied by collateral supply from the other side, or even from let's say if it's the anterior division or the posterior division, the non-embolized artery. However, if you do gel foam embolization and coil embolization, then you really negate that collateral supply, and it can lead to ischemic complications. So it's something we're always quite aware of. And that's it. So thanks very much.
To continue our case, our patient now is 2.5 hours after presenting to the hospital. He continues his tour around the hospital and has his trauma CT scan completed, so full trauma series. This is the summary of his injuries from his CT report. Most significant for this talk are the extraperitoneal bladder rupture and significant pelvic fractures. I think we might be moving on to the next talk.
All right. Next is Dr. Ruben Ambikaipalen, who is one of our orthopaedic surgeons here at the Royal Melbourne Hospital, who has an interest in pelvic and acetabular trauma surgery, and he's going to talk to us about the orthopaedic management of pelvic fractures.
Thanks, David, and thanks everyone for the invitation to talk. I do have 15 minutes and there's a fair bit to get through, so I'll push on as quick as I can. Don't have any real declarations of or conflicts of interest, except I do a bit of work for one of the prosthesis companies in elective surgery. My presentation outline begins with the case discussion that Alicia's run through, but I also want to briefly touch on the early management and stabilisation of pelvic ring injuries, and then move on to how we definitively manage these fractures here, particularly with a focus on percutaneous or minimally invasive fixation techniques, and how that's unique to the technology that we've got available to us at the Royal Melbourne Hospital, and briefly discuss what the future could hold with pelvic trauma management. So as Alicia mentioned, this patient did have a significant injury whilst at work, and we would classify this as a vertical shear type fracture. So essentially the left hemipelvis has really displaced, has really displaced itself from the more stable right side. And given it's an open injury with traumatic wounds, we are limited in some ways about how much metalware we can actively place around a potentially infected wound. So the CT scan very nicely demonstrates that there's a complete sacral fracture on the left side and also some diastasis of the symphysis. And what people don't recognise by looking just at the two images here is that it is actually in multiple planes that the pelvis is unstable, rotationally and vertically. There is also an anterior column fracture on the right side, which does also impact how we would manage this sort of an injury. So the intraoperative considerations here are really what we can do to correct that pubic symphysis. And you'd normally see us try to put either a plate and screws across that and a percutaneous screw up across that anterior column that's injured. But in the setting of a bladder rupture and a traumatic wound, the decision was made to apply what's called an infix. So it's pretty simple to sort of define, but essentially an internal-external fixator, which I will discuss in more detail down the track. And that essentially is stabilising the anterior pelvic ring, and we have a sacroiliac screw at the back. And as you can see here, one of the big limitations with this specific patient was their large body habitus and the fact that it's very difficult to get a good lateral x-ray. You can see that bottom right image there is quite blurry. The patient also had fairly narrow, what we call corridors, so very small bone stock in which to place our screws. And obviously, given the look of the CT, both the anterior and posterior pelvic ring are quite unstable. So this is a demonstration of the infix on your far right. So we do make some small incisions and essentially put two large pedicle screws, which is what our spinal colleagues would use. They're about 1 centimetre wide and about 10 centimetres long. And we bolt them into the pelvis and run a connecting rod that sits deep to the skin. And that then avoids having a large external fixator sitting outside the patient that can cause infection and can come loose. So a very important principle in orthopaedics is if you've got the fixation closer to the bone, it's more stable than when it's sitting outside the body. The other big considerations, as has been mentioned, is the intra-abdominal injuries, and we were only able to fix the posterior pelvic ring with one sacroiliac screw rather than two, given the extensive nature of the injuries, and that's because of that narrow S2 corridor. The one thing I did fail to mention with the infix, we do remove these infix constructs at about the 3-month mark. So that's what did happen to this patient. So this is the initial post-operative imaging, and I do have to accept, I'm sure there's plenty of pelvic surgeons listening online, this is not a perfect anatomical reduction, but given the patient's instability and the degree of the surrounding visceral injuries, we can see there that the symphysis still does have a little bit of incongruence. It's not perfectly aligned. However, our reduction at the posterior sacrum is quite acceptable, and that's very important, given that essentially this is what connects the axial spine to the pelvis. And so moving ahead with the patient now, these are the more recent images. This patient was managed back in 2017. So the first two images you can see at the top there are when the patient went for what's called an examination under anaesthetic. And you can see there, unfortunately, the symphysis has almost moved back into its original position, and it wasn't mobile at the time of manipulation at 3 months post-ORIF. The posterior fixation thankfully remains stable, so the sacroiliac screw remains in situ. And I guess, unfortunately, we did lose this patient to follow-up to some degree, which was a little bit suboptimal. However, I did manage to do a recent phone conversation with the patient just to get an update on how they're travelling. And it does highlight how complex these cases are and the challenges, not only from a general surgical perspective, but an orthopaedic perspective, these fractures can be. Currently, he reports that he does walk with a single-point stick, but only really outside the house. He does have a 2-centimetre leg length discrepancy, which is probably, which is really something we try to avoid, and that's the biggest challenge with vertical shear fractures, is making sure we can sort of level the pelvis post-operatively. He reports, interestingly, some right-sided pain, and probably that's from his anterior column fracture, and he's now no longer working as a result of his injuries. So in hindsight, and that's a beautiful thing when it comes to trauma and orthopaedics, potentially we could have gone with some more rigid fixation internally, but if we had a patient that had a significant post-operative infection with infected metalware, I think we would be pretty disappointed with that outcome. So just quickly, these have been touched on already, so I won't go into too much detail about pelvic binders or skeletal traction, which is rarely used these days. External fixation is not used to a large amount here at the Royal Melbourne, but it is popular at other centres, and it does have some benefits. We use it often intraoperatively to assist us in getting a reduction of the pelvis and then fixing it with screws or plates. And the beauty of pelvic external fixation is you do have multiple pin site options if there are wounds or fractures in certain parts of the bones. The disadvantages obviously are that there are pin site infections and you can damage the lateral femoral cutaneous nerve, which patients do often complain about, you'd be surprised. The one advantage I didn't mention about X-fixers are that you can also fix other fractures. So if a patient has a proximal femur fracture that you need to do a femoral nail in, you can't do that when they've got a pelvic binder on. Moving on, this patient did have a C-clamp, which interestingly, when Rose talks about peritoneal packing and how rarely that's used, pelvic C-clamp is very rarely used. I've been a consultant here for about 3 or 4 years, and I think I've only seen it once or twice, and this is one of the rare settings where we've seen it. It's technically quite demanding to put on. It's often done by non-pelvic surgeons, so our general orthopaedic colleagues, because these patients come unstable at all times of the day or night, and you can cause iatrogenic complications if you don't get the pins in the correct spot. I did want to focus today my talk a little bit on percutaneous fixation and the use of technology here at the Royal Melbourne, and I just wanted to set the scene with another case where we had a young patient with a polytrauma and a displaced pelvic ring, and we, for whatever reason, didn't use or didn't have the availability to use our 3D brain lab, or what we call our hybrid theatre. So we only used 2D x-rays, and you can see there we did end up fixing the pubic symphysis, which looks pretty good, I would say. And then we put some screws in the sacrum at the back. And in all views, we had some what we thought were screws in bone. The lateral view, again, is terrible because of the patient's body habitus. But again, you just take all people as they come, or patients as they come. And this is the post-op CT, and this is what you never want to see post-operatively. And that essentially is a malreduced sacroiliac joint and screws that unfortunately are probably traversing through the L5 nerve roots. Okay, and these are devastating complications. So Juliana did talk about the hybrid theatre, so I'll move on from this, but we've been using it since around 2016. It gives us cross-sectional intraoperative 3D imaging, which is invaluable, and allows us to navigate our screws, and it allows us to confirm the reduction and the screw position on table before you wake the patient up. And as many people have discussed, the reason there's not many pelvic surgeons around is because there's easier ways to make a living, and pelvic surgery is very risky. You want to avoid opening the pelvis if possible. It is very complex anatomy even when it's normal, and it's even worse when it's distorted in the setting of trauma. There are many, many, many neurovascular structures nearby, and we have lots of interventional radiology and vascular friends that come to help at short notice. But patients can bleed very quickly on you. Obviously, the abdominal viscera are nearby, and also patients that have had previous laparotomies or previous scars present a significant challenge. So the issues with open approaches, which is why we try to avoid them, are that often you'll end up making large wounds. You disrupt the clot and the hematoma that's been formed over the preceding day or two when the patient's been in the pelvic binder. We often need cell saver, and we sometimes need that very rapidly. The surgery can be quite prolonged. You can use retractors that can injure adjacent structures, and it can cosmetically leave patients with quite significant scarring. The infection risk, goes without saying, is quite big. So when things go to plan, this is what most patients are left with if they have an infix. A small scar there, another one on the other side, and it's difficult to see, but another small scar there for a sacroiliac fixation. I wanted to talk about the benefits of the hybrid lab in that I'm sure the anaesthetists get quite frustrated. We spend a lot of time sitting in the control room staring at a computer screen and moving screws and lines around on the CT, but we're essentially planning what screws we're going to do. And most of pelvic surgery is actually in the pre-planning. So the technology allows us to plan the trajectory of the screw, the diameter of the screws, and the length of the screws, and that's invaluable once you're scrubbed. We can then use other equipment like pins and external fixation to help us get our guide. So this is what we can plan pre-operatively about where we're going to put our screws. And then this is a quick video of how the Zigo or the intraoperative CT runs. And it actually does work fairly quickly because we do have the patient, what we call having a breath hold. So the anaesthetist obviously stop them from breathing, and that allows us to get a very good image. So it has to run fairly quickly. And this is a great example where we've put some wires in some fairly risky places. So this is a patient that had posterior column fractures, and we've essentially put wires essentially along their ischial tuberosity, so around their buttock, with the sciatic nerve running right there, all the way up inside bone. And that's a big challenge, knowing whether you're actually in the right spot. You can hit not only the sciatic nerve, but you can hit the gluteal vessels either side when you're coming up. And then we run that 3D CT, and we get some great pictures to confirm we're in the right spot. So we can hopefully avoid what happened to that patient I demonstrated a bit earlier. The advances in technology also help us to deal with what we call people with dysmorphic pelvises. So people do have naturally varied anatomy. And as you can see here, this is one of our previous pelvic fellows who is drilling in a fairly abnormal angle. And if we didn't have this technology to demonstrate what angle to drill and to put the screws in, it's highly likely, again, we'd end up with screws in the wrong position. So this technology is not only the 3D intraop spin, but the green and orange lines you can see are what we call 3D Brain Lab, which essentially is the navigation tool that we use to guide our screw positions. Here you can see The S2 corridor, which is the level down from the S1 corridor, is often quite a narrow corridor, and we can quite safely navigate through that with the assistance of the brain lab. Also anteriorly, you can see there's a fracture there, and we can not only tell the length of the screw, but also the diameter of the anterior column. There are obviously always disadvantages of technology. Not everything's all rosy, and as we've alluded to earlier, there is a significant learning curve, not just for us as surgeons, but the nursing staff. We do need to have specialised radiographers, so we can't always use the technology, say, on weekends or after hours. The theatre isn't always available. We do have to share, which we don't do very well as orthopaedic surgeons, but there are plenty of our colleagues that also need to use the hybrid lab. The patient's body habitus can be quite limiting. It is very expensive, as Juliana alluded to, but hopefully that cost is offset by avoiding return to theatres and avoiding significant complications. There is a radiation exposure, not only to the patient, but to all of us as staff members. And this is quite an interesting point. We often have international fellows visiting and working with us, particularly from the UK, and they come and learn these skills. One of them sitting right here. This is Ken, our fellow, who's off to Stoke next year as a consultant back in the UK. And all the stuff that he's learnt, unfortunately, may or may not get used in the future if I don't think any NHS hospitals have access to this sort of technology. And I know when I was at the Royal London, they didn't, I mean, that's the largest trauma centre in Europe, they didn't have access to intraoperative 3D imaging. These are the devastating complications in open fracture fixation. So you can see there, these two patients have bad wound infections. And for most of you that work here at the Royal Melbourne, you'll rarely see patients like this anymore that have plates and screws throughout their pelvis where we've stripped the bone. You avoid stripping the periosteum, and that improves the opportunity for the fracture to heal. There are multiple organisms that can grow when there's bowel and bladder around. And when you get infection, you get delayed fracture union. So you start with an unstable pelvis and then you end with an infected unstable pelvis, and that's a disaster. Just quickly, I wanted to touch on future advancements in pelvic trauma. So 3D printing is now very common, particularly in elective arthroplasty. So that's quite well recognised and is used by a lot of us in arthroplasty. It's a lot more challenging in trauma. There's usually about a 2 to 3 week turnaround in terms of getting 3D printing of fractures. So there's a long way to go for the use of 3D printing. We do have robots. Everyone's talking about robots these days, but we do have robots in elective arthroplasty that allow us to position things or implants in the right position. Again, I would suggest that's a fair way away in the trauma setting, particularly in the pelvis. But the navigation is a pretty good second best. And finally, obviously, everyone's talking about artificial intelligence. And I think this is a great reminder that the surgeon has to always remain in control. You can't blame Elon Musk and the Tesla when the cars are being run off the road. So it may be useful in fracture pattern recognition. Connor did show that slide of all the different types of fracture patterns, and potentially AI could help us with that. But then we wouldn't have the fun of grilling our registrars when they don't know what the fracture is. So hopefully that stays away for a while. It can potentially just tell us what's abnormal and what's normal so that we can flag abnormal x-rays. And this is a big thing in healthcare, is that who accepts responsibility when a robot or something other than yourself is making decisions or in charge. And at the moment, that's always going to be the surgeon in charge. So just in summary, pelvic surgery is complex and it's challenging and it doesn't always go to plan. We are really focusing our efforts on doing percutaneous fixation when able. Technology is a valuable adjunct. It's not the be-all and end-all. And navigation can hopefully reduce misplaced implants, making sure we reduce fractures well, avoid wound complication and avoid revisions. I would like to thank my pelvic colleagues and Andrew Bucknell for supplying some of these images, not the bad ones, I reassured him, but thanks very much.
Thanks, Ruben, for a very insightful and erudite talk. So just before we move on to the next speaker, I'll just remind everybody in person and online that you can ask questions at any stage on the Slido app, and we've already got some of them rolling in. So yeah, as questions pop up, you may as well ask them. We'll put them all together and get them answered at the end. So next I'll invite Dr. Justin Chi, one of our urologists, who's an honorary consultant here at the Royal Melbourne, and as I understand, our go-to person for difficult urethral reconstructions, and he's going to talk to us exactly about that.
Thank you very much. My name is Justin Chi. I'm a urologist, but I specialize in reconstructive urology, often with difficult urethral complications following trauma. I would like to thank you for the invitation. It's been fascinating so far. Very interesting to see advances that have happened here at Royal Melbourne Hospital. Unfortunately, there's no advances in urology on this side. Everything's as it was 50 years ago. So, moving on, I've been asked to talk about bladder and urethral injuries. This one, there we go. There's very extensive guidelines available, free online. One is the two main ones, the American Urology Association from 2020 update, as well as the European Association of Urology update this year. I'm going to start with bladder trauma. So initially we suspect it from often the mechanism of injury. Motor vehicle accidents are the most common, especially if there's an injury, soft tissue injury to the lower abdomen, including seat belts or a motorbike injury. The second is a case similar to this, an actual direct pelvic crush injury. You have to worry if there's any pelvic fracture. Seen here, 2%, but that would be pretty low. I think overall, most urology circles think it's higher than that. Maybe they've excluded the acetabular fractures. And of course, hematural blood in a urethral catheter. Most of these are extraperitoneal, some are intraperitoneal, and about 10% are both. About 10% of the time, they also have an associated urethral injury with the bladder injury, especially if there's a pelvic fracture involved. What do you do? If you suspect it, you do a retrograde cystogram. This could be either conventional or with CT. That's the update for urology. You can do a CT. They have the same specificity. The bladder must be filled with a minimum of 300 mils. So here you've got a bladder that's got about 200 mils in it. Looks fine except for some extraperitoneal contrast. But you add another 100 mils and you see an intraperitoneal leak. So don't accept it if it's not adequate because you will miss these. Ideally, clamping of the catheter and allowing IV-administered contrast for a CT to accumulate in the bladder antegrade is not appropriate. You will miss injuries, and you won't, from either inadequate distension in general. So here's an image of a bladder that looks really full. It's got a catheter in it. This is from a CT contrast accumulation. There are some worrying signs. There's fluid outside the bladder. And of course, when you do your actual cystogram, you can actually see the contrast leaking quite freely. So be aware, don't accept it. It's a cystogram, not a CT with contrast given for the trauma series. Intraperitoneal bladder injuries, first of all, they must be surgically repaired. This can be delayed. I was going to say that in urology, you guys have saved their lives, their bleeding's under control, they're reasonably stable, the pelvis has been fixed and they're going to walk out of here, and then we come into play. So really, they can be stable, even if they've got an intraperitoneal leak. If they're unstable, fix that first. We're just trying to drain urine and then reduce morbidity in the future when they've recovered. If you are repairing an intraperitoneal bladder injury, at the time, you should be exploring for an extraperitoneal injury because you're there. In particular, you should repair bladder neck injuries. No, wrong one. And this is just a conventional cystogram and a CT cystogram of intraperitoneal leak. They're usually quite obvious. The bladder's often collapsed, but if you inject enough, you get a nice swoosh of contrast. Some, and then we're going to talk about intraperitoneal bladder injuries. The vast majority are uncomplicated, and these can be managed with a urethral indwelling catheter alone. In general, we say to leave the catheter in place for at least 2 weeks, sometimes longer. If there's an ongoing leak at 4 weeks, the recommendation is to explore that and repair it, but generally not before. Other injuries may delay catheter removal. So if they've got a catheter for some other reason, they're often in hospital, still recovering, they can keep the catheter until they're able to void themselves. And you would have a cystogram to confirm no leak prior to the trial of void. And this is a conventional cystogram and a CT cystogram of extraperitoneal leak here and here. The case today, there was a nice CT, but it didn't include the anterior abdomen. It mentioned that there was an extraperitoneal leak, but we didn't see it on the CT image. There are cases we do operate on, extraperitoneal injuries, and these would involve, historically, bits of bone in the bladder. These in Australia are all repaired. I trained quite extensively in India, and a lot of those pelvic fractures are not surgically repaired, but those ones you have to repair the bladder. If there's an associated rectal injury, 0.7% here at Royal Melbourne, you have to repair both the bladder and the rectum or vagina, otherwise you'll create a fistula that's incredibly difficult to repair. In fact, the most common time we see it is with my colleagues at the Alfred, the other place. They put X-fisses on a lot, compared to here by the sounds of it, and they also ORIF it a lot. And the most time we're called to repair an extraperitoneal injury is when they've identified it at the time of their ORIF. They've opened it up and they call us to repair it, which is fine. So that's bladder injury, pretty straightforward. Put a catheter in if you can, and then drain it. Urethral injury is very extensive. I'm going to talk only about posterior urethral injury. These are the ones associated with pelvic fractures, the most complex, the deepest in. And they involve injury between the prostatic urethra and the membranous urethra, or the membranous urethra and the very proximal bulbar urethra. They occur exclusively with pelvic fractures. They present about 10% of pelvic fractures generally. About 10% also have a bladder injury. On examination, or symptoms and signs would be blood at the urethral meatus, inability to urinate, perineal and genital bruising, a high-riding prostate on exam. The most important thing is you suspect it, and then you get on and do a retrograde urethrogram. This must be done prior to an attempt at urethral injury, otherwise you don't know what's the chicken and the egg. Did the catheter do it, or did the injury do it? They can be partial or complete disruption. And here's a series of images. There's an injury, but it's stretched here, it's intact. Contrast goes all the way to the bladder with no extravasation. Here's a partial with a leak of extravasation, and here's complete with contrast everywhere, but most importantly, you can't see the bladder at all. This was the case study put up today, and you can see contrast going all the way to bladder. A bit fuzzy here, probably a little bit of a disruption at the bladder neck region, but a catheter should have gone in here easily. So we describe the management of urethral trauma in 3 parts: the immediate, the early, and the delayed. The immediate, of course, is to get catheter drainage of the bladder. If it's a stretch injury, such as this case, or a partial injury, it's where you see contrast in the bladder in particular, a single attempt at placing a urethral catheter is acceptable. In particular, if you can do it in fluoroscopy, check that the catheter goes in the bladder and it starts draining. You need to be aware, many patients have had their CT prior, and there could be contrast in the bladder, so you may be tricked into thinking that it's a bladder full of contrast from your retrograde, but it may be contrast from the CT. So we recommend doing a plain film first. So this is the plain film. Then you do your retrograde. So you know that that's not a bladder. That image could have been with a CT, but it's not. It's empty. You do your retrograde, this is the urethra, extravasation, but contrast is going back into the bladder. And this is valid for an single attempt at a catheter passage. If it's successful, then you proceed to doing your cystogram while you're there to check the bladder for a bladder rupture. What's important about that is you also know that you're inside the bladder when you do your cystogram, because if your catheter's on the right place, you're not going to inflate the bladder for your cystogram. If it fails or there's a complete injury, you put in a suprapubic catheter. Be cautious if you're concerned, you didn't think you got it right, it's not draining urine. Initially, some of these can drain quite a bit of urine, even though the catheter's outside the bladder, because that collection in the retroperitoneum is full of urine as well as blood. So these are examples of catheters. This catheter is outside the prostate, there's in the hematoma, and this one is with the catheter tip outside the urethra, again, somewhere. Not in the right spot. Be aware. Again, if you did a cystogram on this immediately after you put this in, you would know you're not inside the bladder. Suprapubic catheterization remains the gold standard in urethral injury. If you suspect it and you're worried you don't have access, put a suprapubic catheter in. It can be done in any safe manner, so you can do a percutaneous stab cystostomy with or without radiological guidance. In the case of severe injury, soft tissue injury, it can be done via small laparotomy in an open fashion. Once again, once you've got your suprapubic catheter in, you do a cystogram to confirm its position and check for a bladder rupture as well. I'm going to move on to early. So I'm only bringing this up because this can occur in the non-immediate, so a number of days up to a week later. And some of you will see this. They're still on the trauma service, etc. So we like to realign the urethra. So if there's a suprapubic catheter in, we like the urethra to be in line, much like orthopods. We like it in position so we can put something down it. So when it comes to fixing it in the future, it's much easier. Once we get a catheter in and you blow up the balloon, often there's some traction, it pulls the prostate back down, reducing the hematoma. In about 10% alone with realignment, you actually can cure the stricture problem in the future. It's done only when they're stable in a very elective fashion. It's equipment intensive, and it needs to be done by 2 surgeons who are experienced. So this is reasons why we do it. So if you don't realign, you have this big, and you have this hematoma, the prostate's being pushed away, and then the urethra ends up being wherever it wants to go, proximally, and then distally there's a big gap. And this is what an image would look like when it's my job to repair it 3 to 6 plus months later down the track. It's very difficult. Long gap, we have to remove bone to get to the 2 ends together. Whereas if you are able to realign it and you are able to get a catheter through here in some way down the urethra, it's all in line. And at the end of the day, the gap is shorter and is much easier to fix. How do we do that? We put a flexible cystoscope through the suprapubic tract, a rigid scope down below, in theater, 2 monitors, 2 surgeons, eye squeezed in between someone's pelvis, and we shine a light. We look at a light and poke a wire down it. Very basic stuff. And then the wire comes out into the bladder, and then we railroad a catheter over it. And that really helps me in the long term if it can be done. In the delayed fashion, that's where I come in. I believe at the moment I'm the only urologist in Victoria. I also treat everyone from Tasmania to do delayed urethroplasties from trauma, and I get some people from South Australia. It's a very difficult area, and I'm very happy to talk to anyone about any of these cases. Thank you.
Thanks, Justin. Another wonderful talk. Finally, we get to the rectum. Now, David Priddle is one of our senior physiotherapists and here at the Royal Melbourne and a research lead, and he's going to tell us about the pelvic floor after pelvic fractures.
Thank you, David. Yeah, so I'm going to try and make this snappy. I've got a lot of content to get to, and I'm sure we're all feeling it's getting about 8 o'clock, so we'll try and keep this quick. So I will touch on the pelvic floor, the anatomy and physiology, along with the after pelvic trauma study, or as one of my colleagues kindly called the pelvis Presley study, Debbie Stewart, that's yours, as well as some preliminary results from that study and the pelvic floor dysfunction principles for treatment. So on the anatomy, we've already covered a lot about the urological structures, thanks to Justin, as well as the arterial and venous supply, thanks to Connor. So I'll talk about some of the muscular components here, which make up the pelvic floor. There's obviously fascia, ligaments involved in that as well. But the main muscle that contributes to the pelvic floor is the levator ani, as well as the coccygeus, which forms a funnel shape, an upright funnel shape. So in that picture that you can see there on the left, that's looking from the top view down. And they originate largely at the pubis, the arcuate fascia, as well as the ischial spine, and attach posteriorly into the coccyx. And the way that muscles work is the insertion pulls up towards the origin, and so together their contraction will cause a lifting upwards and forwards. And that does help with contraction around the anal sphincters, the vaginal sphincter, as well as the urethral sphincters. The innervation is largely from S2 to S4 and the pudendal nerve. There's 4 muscles that really combine to make those attachments. So the first is there, the puborectalis, which wraps around the rectum as that U shape. The pubococcygeus, which then goes posteriorly to the coccyx, and the ilio and ischio-coccygeus. And so their function, as I said, on contraction, lifts the internal organs of the pelvis and tightens those sphincters. And relaxation allows the passing of urine and feces. In men, for sexual function, the pelvic floor muscles have a role in erectile function and ejaculation. And in women, there's a role for sexual sensation and arousal. And as well in pregnancy, they help support the baby in utero. And these muscles require relaxation to allow the birthing process. And in the picture on the right of the screen, you can see the far right, that U-shaped puborectalis muscle wrapping around the rectum, which when positioned appropriately can help with relaxation and passing of a fecal stool. And then the first picture is that bowl shape that you see of the pelvic floor muscles attaching from the pubic bone round to the coccyx. Imagine that all lifting up and moving forward to help with closing those sphincters. So when you throw a pelvic fracture, such as the case that we've presented here today, into that mix, and as our previous presenters have highlighted, there's no surprise that there's going to be extensive damage to the bone, blood vessels, nerves, urogenital organs, rectum, and soft tissue. And the potential complications that come from that are urinary, bowel, sexual mobility limitations, and potentially chronic pain. And while in theory we know from their general physiotherapy practice that patients recover after their musculoskeletal injuries through rehabilitation, what happens to their pelvic floor? And so this study by Lefebvre in 22 used the International Consultation Incontinence Questionnaire, which is a measure where 0 is the no symptoms and the higher the score is the worst symptoms. Apologies, the formatting's gone a bit off there, but what you can see here is for the urinary bother symptoms, both males and females had a statistically significant worse in their bother at the 5-year follow-up margin. So that continued to progress to be worse over time. This study didn't look at bowel function. They did look at sexual function, and it found that for males, 5 years post their injury, there was a statistically significant worsening of sexual function. Females didn't have a statistically significant result, however, it was still raised as poor. And really, this research supports the initial work that was done at the Royal Melbourne Hospital, led by Carly McConnell, who, thanks to this work, I wouldn't be presenting here today. So Carly found, really, she had a hunch that pelvic trauma was likely to result in pelvic floor dysfunction. So she gathered some patients together from 2015 to 2016 to do this retrospective observational scoping study. And they found that there were symptoms of bladder, bowel, and sexual dysfunction prevalent in females 1 year post their pelvic fracture. And for males, there was statistically significant sexual dysfunction 1 year after. But really what that study did is set us up to be where I am here today, talking on behalf of the full research team involved with the after pelvic trauma study, to ask this question, or answer this question: does a screening and referral process for pelvic trauma patients reduce the prevalence and severity of pelvic floor dysfunction 12 months following injury? So it's a TAC-funded study, and this is a list of the team involved with publishing the protocol to date, and certainly there's more people who aren't listed there that have still contributed to this study. And really would like to acknowledge all those people involved before me and currently working on the study. So the aims of this study are to confirm the prevalence and severity of pelvic floor dysfunction at 3 and 12 months, and also to compare the difference of an intervention with applying a randomized controlled trial format to compare standard care, which is usual practice referrals for musculoskeletal type rehabilitation, compared to an intervention group where we are referring these patients to a continence or subacute clinic to help them with their pelvic floor dysfunction specifically. We also look to explore contributing factors associated with increased risk of developing pelvic floor dysfunction and determine a feasibility and sustainability of outpatient screening and extension of clinical care services to target pelvic floor dysfunction. The patients that we're approaching for this study firstly need to be of 18 years of age or older and admitted under an orthopaedic or trauma bed card at the Royal Melbourne Hospital or the Alfred Hospital. They should have at least one pelvic, sacral or coccyx fracture or traumatic changes on imaging, such as a diastasis. And there you can see the list of exclusion criteria. So we're excluding the isolated acetabular fractures. And then there are a number of other conditions which exclude patients, but there are a few at the bottom, the 3 with the asterisk at the end. If someone has PTA or they're being treated with sedatives for substance withdrawal or then delirium, if those conditions resolve, they can become eligible for the study. And so we screen these patients during their acute inpatient stay. The primary outcome measures to measure bladder and bowel function for males and females is the Modified Australian Pelvic Floor Questionnaire, which is a valid and reliable measure for detecting pelvic floor dysfunction. That includes sexual function for women as well, but for men that's not relevant in that format, so we use the International Index of Erectile Function, which is sensitive and specific to detect change in erectile function in a trauma population. So I'll go through those measures a bit more detailed. These are what we use as our screening tool to identify pelvic floor dysfunction. So for the 4 domains in the Modified Australian Pelvic Floor Questionnaire, or APFQ, they cover different components, 15 questions in the urinary dysfunction for men and women, and 12 questions on bowel dysfunction, 5 questions on prolapse symptoms for women and sexual dysfunction for women as well. And so a 0 is no symptoms, and the higher score is the worst symptoms. And then for men, the International Index of Erectile Function is 5 questions, and they have a reverse scale, so your higher score is actually a normal result, and for scores of 21 or less, that suggests erectile dysfunction. It's just worth noting that this questionnaire does rely on partners and penetrative intercourse for 3 of those questions. So that has had some difficulty for patients to respond to and may be not a really useful measure of sexual dysfunction in this population. In terms of additional outcome measures, we will be using the AIS and ISS scores to determine injury severity, and we'll be using the Young and Burgess classification. We do look at the impact on their quality of life using the EQ 5D and 5L. That starts at 3 and 12 months. And that is able to be used to form a health economics analysis where a higher score, which is the bad score, that equals a higher cost to society. And in terms of an emotional and psychological impact, we're screening with the post-traumatic stress disorder 5 questions questionnaire. It is also done at 3 and 12 months. and it is really used to acknowledge that pelvic floor dysfunction can also have potentially psychogenic components. And so this is an overview of the research timeline from initial screening through to completion at 12 months. And so I'll work through each of the stages that's covered in this. So as I said initially, baseline screening occurs during the acute hospital admission, where we do collect baseline data from the medical file along with those other outcome measures that we just touched on. At 3 months, we contact the patients via email or phone and repeat the modified Australian Pelvic Floor Questionnaire and the International Index of Erectile Function and look at the results. And so if someone has a score worse of 1 point on the APFQ or the IEF in males less than 21, that has them eligible to be in the randomised control trial, which means that they do have pelvic floor dysfunction. It's at that point that they get randomised based on the site, whether they're Royal Melbourne or the Alfred, and offered or also randomised on whether they were surgically or non-surgically managed. And then the intervention that we offer, if they're in the intervention group, as I said before, is the referral to a subacute outpatient continence or urology service or a pelvic physiotherapist if they're privately funded. And the control group is the standard care for orthopaedic injuries. The 12-month follow-up, we repeat the same survey questionnaires, but we also ask a few more details about any of the follow-up that they may have attended for their bladder and bowel that might cover the exercises or treatments that they've received, potentially any number of sessions they've been to, and any barriers that might come up to help us understand really the feasibility of that referral process. And so this is the preliminary data from the observational, so those who have completed the surveys at their baseline, and then we'll go through to the randomised control trial after that. So since November 1st of last year through to last week, we've screened more than 540 patients. Of those, 347 have been eligible, and then 234 have consented. And the representation of males to females there in that percentage accurately reflects what you would expect in this population. It is worth noting that quite a large number really have declined, 101 there, and without getting too much into their personal reasons behind that, most have said that there's not been a specific reason or they're not interested. And in terms of those who have pelvic floor dysfunction, that means that they're in the randomised control trial phase. From the 144 responses that we've received so far, 94 of those people, males and females, have been identified as having pelvic floor dysfunction. And so what that means for males, that's 62% of those in this study have pelvic floor dysfunction, and 71% of females have pelvic floor dysfunction. They then go on to get referred evenly based on, some go to control and some go to intervention, and then the 30 there get referred onwards. We did have 17, I think you can just see it there, who have declined the referral, and there's really a mix of reasons behind that. And so, yeah, it will be interesting to see the final results when we have more data on that to see what the actual consistent theme is behind that. In terms of pelvic floor physio, so when we refer these patients on at that 3-month mark, what we can expect from them to receive in the community is some education about their anatomy and the function of the pelvic floor, potentially the pain pathways that go into explain what they're feeling. There can be manual techniques and neuromuscular re-education and neuromodulation. The impact on sleep and stress management definitely needs to be attended to, along with cognitive behavioural therapy. And you can see that this really is a multidisciplinary team involved to require this type of presentation. But really there is level 1 evidence to support the benefit of pelvic floor muscles in retraining and behavioural interventions for these patients in a non-trauma setting, but we don't actually have the evidence in the pelvic trauma population. So we're really applying the principles to this group in this situation. Just to leave you with some takeaway messages, it's fair to say that we can expect some degree of pelvic floor dysfunction following pelvic trauma that's evident at 3 months and potentially worsens up to 5 years. We look to comment on screening and a referral process once we've completed this study, so that we can't really comment on that yet. And there probably are some work to be done on what the barriers might be to people who want to participate in their pelvic floor follow-up. And just the Continence Foundation of Australia is an excellent resource. If you do want to look into this further, they've got plenty of fact sheets that are really good for your patients, as well as some referral locations. And yeah, it's a great resource, so do take a look there if you're interested. Thank you.
Our patient ended up returning multiple times to theatre, as you can see listed on the slides. On day 3, he had his infix, as Ruben's described. He also had debridement of his bilateral thigh wounds and application of a VAC dressing. He had 10 returns to theatre because his lower limb wounds were very significant, requiring further debridement, washouts, VAC applications, and ended with skin grafting. He had his final operation on day 50 after his presentation. This slide is just to demonstrate that pelvic fractures do come with patients with multiple injuries, and this is the list of his injuries on his discharge summary. On day 59 of his admission, he was discharged to rehab. 14 of those days were spent in the intensive care unit, where he had the range of complications that we commonly see in our severely injured patients. Thank you.
Alrighty. Thank you so much to all of those amazing talks. That's, I think, really set the scene very, very well. My name is Kate Martin. I'm one of the general trauma surgeons. I'm the Deputy Director of Trauma here at the Royal Melbourne. I'm going to let Alex introduce himself. He's one of my colleagues from ED.
Hello, I'm Alex Paspaliaris, one of the emergency physicians and also involved in the trauma portfolio in ED.
Okay, now we have a number of questions that have started to come in online. Maybe just grab that computer. And so if you've got any questions you're wanting to ask, please feel free to put them onto the Slido. We will also do it the traditional way, and if you'd like to ask a question, pop your hand up. Otherwise, as our... we're going to use them too? Oh, I thought we used them for the audience. Oh, you got more for the audience? Got 4. There you go. You want to take one of those, Alex, and I'll stand here. There you go. So we'll take questions from the audience the traditional way, if you can raise your hand, but if you could please let the microphone get to you, and that's really just to make sure that the people online can hear the questions from the audience. Alrighty, I think we've got everybody there. Doing some excellent. Alicia, do you want to come down and join us? Come on, you've done all the hard work. There you go. Oh, it's wonky. Oh, don't put it on a wonky chair. Alrighty, well, we get another chair. Alrighty, I might start with some of the online questions. We'll try to sort of maybe do it in the order of the presentations of the talks might be, I think, a little bit easier. So I guess one of the first questions relates to hemorrhage control, and this one's for you, Rose. Do you think we do use pelvic packing far less than what we used to, I think certainly when you and I were registrars and that growing up. Do you think maybe modern resuscitation techniques have had something to do with that?
Yes, absolutely. I think you had
Here comes a microphone.
If the question was posed as to why we are relying less and less on pre-peritoneal packing, my answer would have been our advances in hemostatic resuscitation, so absolutely, yes.
And there's a similar question, so maybe Connor, you might be best to answer this. There's been a question about leaving the catheter clipped and letting the bladder fill up to act as a form of tamponade for the pelvis until we can get into the angio suite.
Yeah, I think I haven't seen too much evidence around that. It would be pertinent to exclude a bladder injury in that setting as if you had clip the bladder catheter, you could increase leakage of urine into the extraperitoneal or peritoneal space, depending on the bladder injury. So it's not something I think that we regularly do. I don't think I'd advise that.
And Connor, there's also a question about how long before the glue embolization dissolves and the vessel reperfuses?
So that's actually a pretty good question. So it addresses, we have various options available to us in terms of the agents that we use for embolization, and some of them we would never really consider using in pelvic embolization, such as small particles, because the risk of tissue ischemia would be far too high. It would be an intolerable risk. So say, for instance, if you inadvertently embolize the middle rectal artery, you could cause an ischemic rectal stricture or ulceration to the mucosa. So our predominant agent is a gel foam, which is kind of like sponge, and we just mix it with saline and contrast so that we can see it under X-ray guidance. And that's a much, much larger size of particle, even though it's a heterogeneous mix of sizes. It's much larger than, we'll say, the small particle size of 250 microns. So it doesn't get into the tissue, kind of very small arteriolar or capillary bed, and it allows for collateral supply to the tissue. So even though we might block the artery more proximally, we don't end up causing a huge amount of tissue or end-organ ischemia. And a lot of what we're doing, as well as blocking the site of extravasation, is reducing any perfusion pressure to that area of injured tissue, and reducing the pressure difference between the systemic circulation and the defect in the artery. As far as glue goes, it doesn't dissolve. It's permanent, so it's there for life. It can move, but we prefer for that not to happen. Coils, again, also permanent. They don't go anywhere, but coils are quite safe in that they're a very controllable proximal embolization, and if you do it properly, then you can ensure that there's good collateral supply to the relevant organs. Glue, again, you would only do it if you were microcatheter, who's in an extremely distal position. So literally, sometimes we're outside of the vessel in the pseudoaneurysm or in the area of extravasation. You start injecting the glue and then withdraw the microcatheter simultaneously until you block that site of injured vessel, but without compromising any other territory. So yeah, we would take all of those factors into account when choosing which agent to use.
Just to confirm for our ED colleagues, it's the same glue we use to...
No,
it is different? Or is it similar?
It's slightly different. It comes in a kind of very small vial, and it's a purple colour.
Yes.
Yeah, it's the same
yes.
stuff. Yeah.
The one where you get your finger stuck on the patient? Yes. All right.
We do. It's very effective.
Okay, this might be a question for Justin, I think. Maybe in my past life, as a less experienced person, I would have maybe asked our interventionist to do a bit of a sneaky retrograde urethrogram, and then if it was an incomplete injury, maybe use a guide wire and pass an IDC in angio, if the patient's already there for their angioembolization. Is that a good idea still, do you think, or do we think we should be including you earlier?
I think a single attempt with a catheter alone is the ideal way to do it. Many people want to do other things like use a flexible cystoscope down the urethra to try and find their way into the bladder, then put a wire, then push. The problem with that is there's a lot more forces. You can convert a partial injury to a complete injury. The cystoscope is not a good idea because you're irrigating with fluids, often filling up the retroperitoneal space with irrigation fluid, and therefore introducing bacteria, risk of infection, etc. So a single attempt at passing a catheter, if it goes in, great. If not, suprapubic catheter. Don't be scared of suprapubic catheters.
Okay, I've got a question for Ruben. At what times would X-fix be more appropriate than percutaneous fixation? Does visceral injuries or time of intervention affect this decision?
Yeah, thanks. So very much so, the visceral injuries. We've got a current patient who's got fecal contamination in and around their abdomen, and we definitely would be avoiding putting any sort of internal fixation or percutaneous fixation for that matter. And again, anyone with sort of anterior-abdominal wounds, you would go to XFix. But again, here we would prefer to just go down the path of an infix in that scenario because, again, it's far more stable. And XFix has a lot of problems in terms of being able to nurse patients, being able to mobilise patients, which prevents PEs, pressure sores, etc. So really at this hospital, if we were going to do any sort of fixation, we would prefer to go to infix in the setting of visceral injuries or contaminated wounds.
Excellent, thank you. And just keeping with you there, Ruben, just can you explain how the 3D operating system works? Again, maybe just a recap of, we've seen the pictures and what you can do with it, but how do you get those fancy pictures?
So probably didn't put up enough pictures of the brain lab. I thought you might get sick of seeing that. But brain lab, essentially what we would do is put some arrays that basically attract to a brain lab, which sits, it's like a vertical stand with some cameras attached, and that basically maps out the patient's anatomy based on the CT scan. So we have the intraoperative Zigo that does the spin, and then we also have the brain lab. And brain lab's used by the neurosurgeons, by spinal surgeons, and it's essentially a navigation tool. So the Zigo speaks to the brain lab, and that then feeds back to the surgeon who's holding the drill that also has arrays on it, and essentially you're, for loss of a better word, playing a video game really, and you're just matching what the brain lab does to where your hand position is, and it in some ways takes the skill out of needing to do it manually.
I think it's like those Wii machines, you know, the virtual golf and stuff like that.
Yeah, you just match the green to the red and fire it in. Yeah. Anyone can do it.
We've got a question for David. What, if anything, should we be telling our patients about potential pelvic floor dysfunction in the acute setting prior to discharge?
Yeah, without influencing any of the results, I suppose. But yeah, I think that you need to be sensitive to the fact that that could occur and that an early referral could be of benefit. I think, yeah, it's a very common situation, and reassuringly, we know that there's really good evidence behind the treatment for pelvic floor dysfunction.
Sorry, and I was just going to ask, do you think, it seemed that a lot of patients didn't want to participate. Do you think that's because they're embarrassed and it's a sensitive topic that I don't like to talk about?
Yeah, I don't get that impression by talking to these patients. I get the impression they're more, it's a difficult time in amongst these trauma admissions. Like they're often multi-traumas. There's a lot of other things going on in their life around that, and people aren't really in the right mindset to think about contributing to research at that point in time. So that's what I generally get as a feel for those who don't want to comment. Yeah, you can feel a bit like a telemarketer rocking up to someone's room and talking about a study, so there can be a bit of work in the sale as well. But yeah, I think it really is that there's so much going on for these patients, and it's just another thing that I don't really feel the capacity to manage.
Now, there are still a lot of IR questions here, Connor. I think you're pretty popular. I'm going to put two together. Potential complications of gel foam embolisation, but maybe more broadly, does it ever result in ischemia to pelvic organs, and I would also say soft tissue? And does this impede healing, whether it's of fractures, but also soft tissue injuries that often occur in the region?
Yeah, so I'd say first off, it certainly is something that we're very cognizant of, more the soft tissue side of things. Of course, if you embolise with impunity and chose the wrong agent, you could cause all sorts of complications, but the gel foam is quite forgiving, and we're quite careful to use coils selectively and glue super selectively, so as I alluded to before. So while it certainly is possible, we don't see it too often. The major complication what we would be worried about is soft tissue ischemia and soft tissue necrosis and formation of ulcers. So, not only these patients may be immobile on the ward for quite some time and at risk of pressure ulcers anyway, if we do compromise the ability of the internal and external iliac arteries to, I suppose, supply the tissues via their collateral pathways around the areas that we do embolize, then yes, it can lead to that, but thankfully there are probably only 2 cases in the last 10 or 15 years that I can even remember. hearing about. And the kind of thing that we would try to avoid, or that we found increases the risk of that, is combining two modes of embolization. So I would say if we use coil embolization on one side and then on top of that administered gel foam bilaterally, then that can cause a significant reduction in the perfusion to the end tissues. So we try and be selective as we can, and the CT really does help with that. So if we can identify like one area of extravasation, take care of that, then with either coils or glue, then we may, and depending on the hemodynamic stability of the patient as well. So if they respond or if they aren't that unstable to begin with, then we might just leave it there and then watch the patient afterwards. And we always have the option of going back if we need to. So there are always factors that we're, I suppose, taking on board and considering. It is a risk, but generally we feel we can do it very, very, very safely, and it's quite effective.
Thank you.
Okay, I think we have a question from the audience.
Yeah, I'm Ken, the Pelvic Fellow. The question to David, do you think the study that you're doing, was there a power, two questions, sorry. Was there a power analysis to look at the minimum numbers that are required to make a decision whether intervention helps or not? And the second question is, given the issue with recruitment, which may tie with this, I find from observation that a lot of the sexual dysfunction, urinary dysfunction, really comes to light at 3 to 6 month follow-up. And you have to ask it directly, because it is, I think there is a big stigma, and it's a shame. And I wonder whether maybe in a future study we should, or regardless, be screening at that period, because in the acute setting, as you say, there's polytrauma, there's everything. That's not really at the top of your mind, unless you've had maybe a devastating injury, but it's pretty clear that you're going to have a poor sexual function. And I wonder whether the screening really has a tool in clinic rather than in the hospital, or in addition.
Yeah, thank you. So the first question about the power, so it is powered to draw those results. So we have a target of 384 for the randomized control trial that should be sufficient to draw those details about the intervention. The second point about the timing for asking about sexual function, I think we're screening at 3 months. We're asking these questions then, and I haven't looked at every single result, but a lot of the patients are finding that hasn't come up as their priority at that point in time. Many of the patients are still going through the rehabilitation phase, so it's not really seen for those to be a particular important priority. So yeah, somewhere along that 3 month to 12 month time point, we aren't assessing in between there. There may be scope for that. We may be able to get more details in our 12-month follow-up.
Thank you. Now, we can't let Juliana get away. We've still got enough time, and Alicia too, I've got one for you. They'll be quickies. So Juliana, I know when we've got these big resuscitations going on, there's blood product going on, everything's happening at once, where would you rather be doing this? Down in the ED, up in a regular theatre? We know you don't want to be in IR, so that's not an option. I don't want to be in IR either, and I don't think Rose does either. No offence, Connor. But, or in the hybrid suite, because I think part of it, it's an ongoing resuscitation of which surgery is part of it and IR is part of it. Where in your nirvana would you like to be, and why?
Well, I mean, never is the first answer, but if I have to do it, probably the hybrid suite. It is definitely much bigger than the angiography rooms that are on level 1. The access to the blood gas machine, the rotum, it's just there, so we don't have to keep sending staff off to, help guide our volume resuscitation. And in addition, when the surgeons do discover additional injuries that need to be managed, we can actually get the scrub staff and the equipment to do that all at the same time in the one location.
Alrighty, and now Alicia, you get the last question. So you're at the front line a lot. You're there when these patients arrive. We've had a question regarding pre-hospital care. So I'm asking you just because you're often right there at the receiving end. We know hemodynamic stability is important, or resuscitation is important. What could we do to improve ambulance care? So I guess it's What do you see has worked well? Those patients with these devastating injuries that do arrive but seem to have been, kept going, what are the things that you see that they've had done that you think that's made a difference to that patient?
I think a lot of it is just doing the basics and doing it efficiently and well and getting the patient to hospital quickly. So the things like IV access, pelvic binder, obviously like we were talking about multi-trauma patients, injured patients, so making sure that the other injuries are sorted if there's a pneumothorax, all of that sort of thing. But yeah, I think the priority is just to get to hospital quickly, really.
Excellent. Well, it's 29 past, so I think on behalf of Alex and myself, we'd like to say thank you very much for attending. Thank you to all of those online for your contributions. And a big thank you to our panel members for all the hard work they put into their presentations, but also making themselves available this evening for what we think is an important program, the Victorian Trauma Grand Round series. So thanks, guys. We'll let David say some closing words.
So I'd like to thank everybody for their contribution and just say it's been a treat to have people in person again at one of these compared to we coped during COVID online, but this has been enjoyable to have people in person, and it's accessible having it online as well, so best of both worlds, almost hybrid in its own way. Can I just remind everyone that there's a feedback QR code on the program, and I implore you to fill it out not only so we could look at improving the quality of the educational product we give you, but also if you've got anything you'd like to hear about at the next Victoria Trauma Grand Round, there's 4 of them a year, don't be shy, suggest something. So let us know. So once again, thank you everybody for your attention, for those that attended here and online from Australia and from abroad, and we look forward to seeing you at the next Victoria Trauma Grand Round.